We are live, I believe.
Yes, sir. Hello, everyone. I'd like to welcome everyone to today's webinar, Life-Threatening Headaches in the Emergency Department, Can't Miss Causes and COVID-19 Connections. The webinar today is brought to you by EB Medicine, and I'm your host and moderator, Sam Ashu. I'm an emergency physician here in Florida, and I'll be with you throughout the event today and then leading the question and answer session at the end. During today's presentation, you will all be in the listen-only mode. And if you're unable to hear or see the presentation, or really if you have any technical issues at all, you can send a message through the chat, or you can visit www.ebmedicine.net/contact. So we're monitoring both of those things at the same time. If you have questions for today's speaker, Dr. Sloan, you can submit them at any time during the webinar. And at the end, during the live Q&A session we're going to have, using the Ask a Question button there at the bottom of your screen. You can also see the questions that other people have asked, and if you think a question is particularly important and you want to be sure that we address it, you can give it an upvote by clicking the arrow to the left of the question. After the presentation today, you will have access to the slides, the recording, all the additional content and reading materials for this activity and the CME evaluation. You'll receive an email tomorrow with a link and instructions to access all of those materials, and you'll have access to them all the time at www.ebmedicine.net. And now on to today's speaker. This is Dr. Edward Sloan. He is Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. He's also the medical director of the Physician Assistant Studies program at Dominican University in Illinois and president and board chair of the Foundation for Educational Research for Neurologic Emergencies. Ed, off to you, sir.
Thank you very much, Sam. It's a pleasure to be with you all from all over the world. In the next 40-some minutes, we're going to go through many concepts that drive how we manage patients with headache, diagnosing the severe causes of headache or the serious causes, and looking at some COVID-19 concepts. I've worked in the urban area of Chicago for 20 years, and I've done some work in rural areas, including my current work at Carle Foundation Hospital down in Champaign, Illinois. I'm working now with physician assistants, but I've worked with residents in emergency medicine for many decades. Thank you to Sam, Erica, Angie, Stephanie of the EB Medicine Group, and thanks for all of you for being a part of this today. I have no financial conflicts. I am the firm president and board chair, and we're interested in educating in neurological emergencies. The educational objectives, we want to increase knowledge and competency through good strategies for taking care of patients, improve your performance in practice, and improve patient outcomes. Today, we're going to look at secondary headache etiologies, look at how patients present, diagnose, and treat them, and consider the issues related to headache and COVID-19. So an overview, I want to tell you that this content comes from a monograph, Evaluation and Management of Life-Threatening Headaches in the Emergency Department by Drs. Zoda, Procopio, and Gupta. It was published by EB Medicine and Emergency Medicine Practice in February 2019. Thank you to them for their work. This is what it looks like. Emergency Medicine Practice does a great job with all of their clinical monographs. Our pathologies that we're going to look at, 3 involved structures: the CNS tissue itself, both the brain and spinal cord, the blood vessels, and the meninges. And we're going to consider primary and secondary headaches. Our etiology and diagnoses: a headache is a pain in the head, clearly, and it's a vexing or baffling situation or problem such as that we are in today worldwide. So headache etiology, the primary etiologies, most of them are cluster, migraine, and muscle tension headache that incorporates 90% of headaches. The 10% of secondary causes are ones related to infection or dehydration, such as sinusitis, pharyngitis, vomiting, dehydration. But there are other life-threatening secondary diagnoses that we'll talk about today. And here's a list of those diagnoses in 2 slides, and then we're going to go through them individually throughout the program. So headache history. The OPQRSTU system is a great system: onset, provocative, palliative, quality, radiation, severity, temporal, and are they under the care of anyone? And I've circled sudden severe headache and whether or not there's pain in the neck. These appear to be important issues, especially in retrospect if someone has a serious life-threatening headache etiology. So associated items: do they have infection symptoms, ENT? Do they have dehydration symptoms, stroke symptoms, cardiovascular symptoms, near syncope, remote trauma, which could have occurred many days ago, and or a headache history? So what are our red flags? Sudden severe or thunderclap headache, new onset headache, neck pain that is significant, not just mild neck pain, malignancy history, immunocompromised, syncope, and or pregnancy or being postpartum. The physical exam, we want to know, do they have fever? Clearly, you need to know if they're abnormal vital signs. Are they hypertensive? Do they have a Cushing's response? Do they appear well? Do they have altered mental status? Do they appear dehydrated? Are they in distress? Do they have a rash, skin changes, any dysrhythmia on the monitor? And do they have any chest, GI, or GU infections that could be causing them to have a secondary headache? Now, when you look at the HEENT exam, I'm going to leave out eyes for now. You want to know whether they have sinus or temporal artery tenderness. Are their tympanic membranes or ear canals normal or abnormal? Do they have signs of pharyngeal or a retropharyngeal abscess? Do they have sign of a dental abscess? Nasal polyps or green discharge? Neck swelling or tenderness? Do they have a bruit? And most important, do they have signs of meningismus? Looking at the eye exam, it's actually so much you can learn if you do an eye exam on most of your patients who appear ill. What is their visual acuity? Can they finger count? Is there a visual field abnormality or cut? Do they have diplopia with either vertical or horizontal gaze? Are their pupils equally round and reactive to light? Do they have a Marcus Gunn pupil that shows that they have an afferent defect? Are their extraocular muscles intact, cranial nerves 3, 4, and 6? Do they have a lid lag, which would suggest cranial nerve 3 palsy? And is their fundus okay? Is their disc sharp or is there papilledema? The neurological exam, AVPU, alert, responsive, verbal, pain, or unresponsive. What is their mental status? Speech. Do they have dysarthria? Is there motor functioning abnormalities? Is there truncal ataxia? Or standing, do they have a Romberg or abnormal gait? Finger to nose coordination, abnormal reflexes, and a neuropsychiatric assessment. What are the exam red flags? Clearly altered level of consciousness, seizure, fever, meningismus, visual acuity changes, cranial nerve abnormality, focal deficit, or psychosis. Laboratory testing includes those listed here. Note that ESR and CRP have some limited sensitivity for giant cell arteritis. You do want to know if there's a venous CO level that needs to be done because multiple people have headaches in the same place. And note that the D-dimer can exclude cerebral venous thrombosis in low-risk patients, and we'll come to that. What about the lumbar puncture? Obviously, you need to know whether or not there's any signs of increased ICP on CT. I would recommend that always before an LP. You need to know what their opening pressure is like, at least to know whether the fluid's coming out very fast, and you must do a CT in the left lateral position in order to do that. You want the smallest amount of fluid in each tube, and the 4 tubes listed here: hematology, chemistry, micro, and repeat hematology. What about neuroimaging? We know that non-contrast head CT is low yield, but it has high clinical utility because it's accurate and it allows us to disposition patients. All ED patients that require neuroimaging, this is the best first test. It excludes many diagnoses such as those listed here. Neuroimaging in headache patients. In 2008, ACEP put together a clinical policy. They asked 5 questions and they gave us recommendations. And the level B recommendations: you should consider an emergent CT for new abnormal findings on neuroexam, new sudden onset severe headache, and HIV positive patients with a new type of headache, not just their normal headache. Level C recommendations, you should at least think about patients older than 50 years of age with a new type of headache. It should be done emergently or at least urgently in the next few days. Other headache neuroimaging, CTA or CTP for ischemic stroke. CTA can be done to exclude aneurysm and subarachnoid hemorrhage. MR venogram for patients with suspected CV thrombosis. MRI for vasogenic edema in those who have encephalopathy and presumed increased ICP. And you can do a CTA and or MRA of the head and neck if a dissection in the cervical arteries is suspected. So here's our first question at 10 minutes. Which patient does the ACEP clinical policy on ED headache evaluation and management recommend acute imaging for? Stephanie?
Great. We're going to stop here for just a moment. In the bottom right of your screen, next to the Ask a Question button, there is now one that says polls. So we're going to have you click on that, choose an answer, and I'm going to give you 20 seconds. And then Ed will take over again.
So what did we have, Sam?
We are, hang on. Votes are still tallying. So far, we've got 94% people choosing a new abnormal finding on neurologic examination.
Perfect. That's clearly the most important emergent indication, and that is the correct answer. You know, one other thing that can be done is optic nerve sheath ultrasound and headache. It is done to help you assess whether there's increased ICP. And when the optic nerve diameter is greater than 5 millimeters, it predicts an ICP greater than 20 millimeters of mercury, and it acts as a bedside type of CT to assess elevated ICP. So our secondary etiologies, here's those lists again, and let's start going through those. Subarachnoid hemorrhage obviously is the most important diagnosis. It is the most important secondary headache cause that's life-threatening. And the sudden severe thunderclap headache is pathognomonic for a subarachnoid hemorrhage. I put the 3 asterisks because those will show that those are questions that you might be asked for CME, and pay attention to those statements. You know, a sudden severe headache is maximal and severe in intensity within minutes. It's obviously subarachnoid patients have significant morbidity and mortality. We'll talk a little bit about the timing of the sudden ictus, but the point is whether or not they come in quickly after this ictus or in a delayed fashion, and we'll go through some different strategies and policies. This image shows you on the left the stellate collection of blood that corresponds to the same distribution of the circle of Willis seen on the right. We talk about likelihood ratios, and values greater than 1 increase the probability of disease. So you could see that a value of 1 doesn't do much for you, and a value of 10 increases your likelihood by 45%. So let's take a look at this. If your pretest probability of a subarachnoid in a patient is 10%, and you have a positive LR of a symptom or sign such as meningismus, which is 6.6, it increases your probability by 35%. Your post-test probability increases to 45%, and your pretest odds go from 1 in 10 to now almost 1 in 2. And so let's look at these numbers. You can see that meningismus leads the list with 6.6. And if you look at the most important ones, they are meningismus, neck stiffness, focal deficit, photophobia, and any loss of consciousness. These raise your risk from pretest probability between 15 and 35%. If you look at the Ottawa subarachnoid rule, it has high sensitivity, but is relatively low specific. That is, few false negatives, but many false positives. And if you look at the exclusion criteria, they're quite detailed. But let's summarize this by going right to our electronic medical record. If you can say all of these were negative in a test that's 100% sensitive, and you develop a dot phrase where you say all of these findings are not present, then you could say the risk approaches 0, such that testing beyond non-contrast CT is not clinically indicated, the patient is aware, and they agree with the plan. So I think this is the most important value of the Ottawa rule. Now, subarachnoid hemorrhage testing based on the ACEP clinical policy. Remember, you only need to worry about subarachnoid for sudden severe headache. Other headaches don't require this type of analysis. And if you do have someone with sudden severe headache, they do require a lumbar puncture. But remember, most patients do not have a sudden severe headache. So most of the recent literature does suggest that our ability on CT alone to detect blood in less than 6 hours is quite good, such that if you have a negative CT in a patient who you believe is relatively low risk, you've reduced their risk by at least 50% just with that negative CT. So if you think their likelihood is 1 in 100, you've reduced it now to 1 in 200 just with the negative CT. Now, there's also the recommendation that you have to be aware that they have normal opening pressure on LP. Now, we don't normally order or obtain opening pressure, but suffice it to say, if the fluid comes shooting out quickly, you know then they may have increased opening pressure. If it only drips out minimally in order to fill your tubes, they do not likely have an ICP above 20. LP versus CT angiography. The concept is if there's no aneurysm, then there's not likely a subarachnoid hemorrhage. And we do CTAs because we can evaluate down to 6 branches. And we know that a CTA will be of more value clinically acutely than would be an MRA. So the CTA is the test of choice. And why is this? Because when patients present acutely less than 6 hours, LP is not a useful test. CT and CTA are more useful. The treatment is listed here, trying to manage blood pressure, nimodipine, calcium channel blocker. You can't give any anti-epileptic drug therapy, but there's limited data to support that. And ultimately, you want to manage the aneurysm with a clip or a coil. All right, we're here now ready for our second question. Which of the following historical examination findings is most suggestive of subarachnoid hemorrhage? Sudden onset, neck stiffness, focal deficit, or loss of consciousness? Sam?
Okay, everybody, bottom right corner, next to the Ask a Question button, you have 15 seconds. All right, Ed, 92% are voting for A, a new abnormal finding on neurologic examination.
Is that, I think, actually, a sudden onset, but go ahead.
It's a different order, actually, on the poll than it is on your slide.
My apologies. And which one are they choosing?
Sorry, I'm looking at the wrong question. It always helps when I'm looking in the right place. All right, this question, 88% are picking A, sudden onset of headache.
Clearly, remember, you do not need to worry about headaches and subarachnoid unless it's a sudden severe thunderclap headache, and that's the answer A. So let's go on to our next diagnosis. Cervical artery dissection, carotid or vertebral artery dissection, presenting with neck pain, perhaps some remote mild flexion extension injury. They can, with carotid artery dissection, have anterior circulation stroke symptoms such as hemiplegia, slurred speech, or Horner's syndrome. And remember, in the setting of cervical artery dissection, there can be delayed neurological symptom onset. They may have neck pain for several days, but not develop a neurological symptom until the dissection has progressed. You can see on the left, this is a graphical or artistic representation of the disruption. And you can see a defect by the red arrow on the right on MRA that shows you a carotid artery dissection. Now, with this, you can see a Horner's syndrome because of some tension on the third nerve. And she has a left eye ptosis, an eye droop, and miosis, a pinpoint or smaller pupil. This is important because you know anytime you suspect this type of diagnosis, you must document that the patient does not have a lid lag. They have no ptosis or miosis. They have equal pupils and their eyelids are equal. And again, the Horner's is due to sympathetic stretching in the area of the carotid artery. The vertebral artery dissection, again, neck pain, flexion extension can be mild, can be remote several days ago. Posterior circulation stroke symptoms, dim vision, dizziness, diplopia, dysarthria, discoordination, hemisensory complaints. These are all the things you think about with a posterior circulation problem. What is our management of cervical artery dissection? Medical management to prevent stroke, regardless of whether it's spontaneous or traumatic. They found in the CADIS trial that antiplatelet therapy and antithrombotic therapies are comparable. If it's extracranial, you give IV heparin, then oral anticoagulation. If it's intracranial, you give aspirin or clopidogrel. If you can't anticoagulate, you clearly would then give aspirin or clopidogrel. And bear in mind, for most cases, aspirin and Plavix are only used together for cardiac problems, not neurological. It seems for neurological diagnoses, if you use both, your risk of hemorrhage is slightly increased. Cerebral venous sinus thrombosis. This is more common in pregnant or postpartum females, hypercoagulable patient states. They may demonstrate increased ICP signs and papilledema, and cranial nerve 6 palsies can be seen in these patients. They can have stroke symptoms such as hemiparesis, posterior circulation symptoms, ataxia, seizures. And bear in mind, if you think the patient does not have a cerebral venous thrombus, if they're low risk, a negative D dimer continues to exclude the patient, but it only works in low risk patients. If you really have an elevated index of suspicion and they're moderate or high risk at your onset following your exam and history, then you can't use a D dimer to exclude. This is a great MR image. You can see in A, there is a patient who has a venous cerebellar infarct as a result of poor flow through the transverse sinus due to occlusion, the dark area here. 3 months later, you could see the stroke has resolved, but there is still maintained poor circulation through the transverse sinus. So this is a good demonstration of how CV sinus thrombosis can cause stroke. Now, remember, if you believe that if it's an infectious etiology, such as sinusitis with cavernous sinus thrombosis, you must give antibiotics. Anticoagulation therapy is recommended, but remember, 1/3 of these patients will present and have some type of hemorrhage. So you must do a CT and both an MR to make sure you don't see punctate hemorrhage. And if you can anticoagulate, then you give low molecular weight heparin, then oral anticoagulation. Idiopathic intracranial hypertension. Women of childbearing age, a common story that someone was on steroids, but they didn't like the way they made them feel, so they suddenly stopped them. This is long-term use, not brief use. Symptoms seem to change with position change. They can have pulsatile tinnitus and a cranial nerve 6 palsy, so it's important to check for extraocular muscles. They can have horizontal binocular diplopia, which is double vision when you have them gaze laterally. You can diagnose this using modified Dandy criteria, and bear in mind that ICP is generally greater than 20 to 25 in patients with IIH. What's the management? You can do an LP with fluid withdrawal as a temporizing measure. That can be problematic. You don't know exactly how much to draw off, which could make their headache worse. But ultimately, the weight loss, low sodium diet, acetazolamide will give you some improvement, especially if there's a visual field problem. You can give topiramate or furosemide as alternate therapies. And at times, surgical options can be utilized if there's no relief with medical therapy. Giant cell arteritis. You can see this in older patients. Those patients will have temporal artery tenderness. The sign with the highest positive likelihood ratio is beating, noted on palpation of the temporal arteries. So every older patient who presents with headache, you need to document no temporal artery tenderness or beating. The patients can have jaw claudication. That is, as they chew steak or meat or whatever, they'll start to get an ache in their jaw. They can have diplopia, some portion of vision loss. And you must remember to exclude central retinal artery occlusion, CRAO, in the differential of anybody with acute vision loss where you're considering giant cell arteritis. This is the alternate diagnosis to consider. Treatment here is high dose methylprednisolone. You give a high dose, then oral prednisone. A biopsy is indicated, even if they have normal ESR and CRP. And remember, I said that you must exclude CRAO. The reason is if you believe that they have an acute central retinal artery occlusion, TPA might be indicated, whereas with giant cell arteritis, the treatment is methylprednisolone and steroids over time. What about posterior reversible encephalopathy syndrome, PRES? This is basically encephalopathy that is due to loss of autoregulation of the CNS vessels. You know that across a broad range of systemic blood pressures, your CNS pressure remains relatively stable. If blood pressure causes your CNS vessels to lose their autoregulation, you have a problem. Acute headache, hypertension, altered level of consciousness, visual changes, seizures, and these symptoms actually occur over hours to days. It won't occur in minutes, but over several hours to days. If patients all of a sudden develop an altered level of consciousness and they're hypertensive, you know this is the likely diagnosis. Now, you want to lower blood pressure to a safe range. And when we say safe, what does that mean? Consider the 185/110 used for TPA evaluation, and consider mean arterial pressure when you're treating. And they say you want to lower your MAP by up to 25%. So let's look at this. Mean arterial pressure is 1/3 systolic, 2/3 diastolic, because you spend 2/3 of the time in diastole. A normal 120/90 is a mean of 100. 185/110 is a mean of 136. And when someone is 210/135, their mean is 160. If you lower it by 25%, you're going all the way down to 120. And my point is, if you reduce mean arterial pressure to around 130 to the 180/105 range, there's no need to further reduce blood pressure, especially if that's done quickly in the emergency setting. What antihypertensives can be utilized? Nitroglycerin is a good venodilator, especially if there's signs of cardiac ischemia. Esmolol is a cardiac beta blocker, especially useful when tachycardic. I've utilized through most of my career labetalol. It's both an alpha-1 and a beta blocker. It's especially useful when patients are tachycardic, and you can give up to 20 to 40 milligrams every 10 minutes. And I think this is the most useful and reliable bolus injection as opposed to continuous infusion. If you must use continuous infusion, there are two good antihypertensives that can be given by continuous infusion, both calcium channel blockers. Nicardipine, start at 2 to 5 milligrams per hour. Clofidipine, you can start at 1 to 2 milligrams per hour. There's no reason not to use these in the emergency setting. These continuous infusion meds are quite reliable. They're quite titratable. They're used especially with hypertension and encephalopathy, and they're often used in the neurointensive care unit, and we could also. Meningitis and encephalitis. Remember, there's both bacterial and viral meningitis. If a meningitis or encephalitis is suspected, you must give ceftriaxone prior to sending the patient for their non-contrast CT. Get the ceftriaxone early. Steroids are recommended, but this is only if you have a confirmed CSF that is cloudy and you believe it's a positive LP suggesting bacterial meningitis. Otherwise, the study that indicated steroid use doesn't suggest it should be used empirically as you would with ceftriaxone. Here are the microbes: strep pneumonia, group B strep, N meningitis, H influenza, and listeria. Remember, non-polio enteroviruses, group B Coxsackie and echoviruses can cause meningitis. And remember, patients with altered mental status who have a fever, who appear to be out of their mind and they were normal the day before, you must consider encephalitis. Now, when you look at the microbiology and you consider what antibiotics should be used, it's really based on what the likely microbes are. You can see there's a lot of higher generation cephalosporins, cefotaxime, ceftriaxone. Ampicillin is used in younger infants. Vancomycin is used in adults and when there's foreign body or a procedure. And for pen allergy, moxifloxacin and vancomycin are recommended. Acute angle closure glaucoma. This is more common in older patients. It's the story is they were suddenly exposed to bright light. Someone left a movie theater to a sunny day. Then they have unilateral blurry vision, halos, vision loss, unilateral headache behind the eye. The eye will be red and painful. The intraocular pressure is normally above 30 with this disease, knowing that your normal intraocular pressure is about 8 to 20. How does it happen? Your normal aqueous humor goes from the posterior to the anterior chamber into your bloodstream. It has to pass between the iris and the lens and through the pupil opening. If that gets blocked, it's known as a pupil block. And in acute closure glaucoma, the iris is so close to the trabecular meshwork that when you get any degree of pupil block, they get decreased outflow. How do we treat these patients? It's most often medical management, timolol, a beta blocker, pilocarpine, a miotic, aproclonidine, an alpha-2 agonist. You can put all three of these drops in and send them right to the ophthalmologist's office where they can often do immediate laser therapy in the office as needed. Pregnancy-induced hypertension. This is hypertension associated with symptoms and or lab findings. It's 2 readings above 140/90, 4 hours apart, or 1 reading above 160/110 millimeters of mercury times 1. Now, it has to have these blood pressure findings plus proteinuria or these other 5 findings, which are more significant: thrombocytopenia, liver, renal impairment, pulmonary edema, or new onset headache. Knowing that new onset headache is the most important thing that makes you know that this is a more serious or severe case of pregnancy-induced hypertension. You can give labetalol, as we mentioned. You can give nifedipine PO. If it's severe, you can give magnesium sulfate, 4 to 6 grams bolus over 30 minutes. And then you can give 1 to 2 grams per hour until you get muscle or reflex changes. They'll get changes in their extraocular muscles. They'll get limp. They'll lose their reflexes. At that point, you must stop the magnesium. All right, we're ready for our third question. A 25 weeks pregnant patient presents with a blood pressure of 180/120. Which of the following associated symptoms requires IV magnesium for the treatment of what is presumed to be more severe preeclampsia? A, proteinuria, B, new onset headache, an elevated protein creatinine ratio, or an elevated serum creatinine.
All right, everybody. Down in the bottom corner, next to ask a question. Votes are being tallied. You got 15 seconds. And that's time. All right. 89% have voted for B, new onset headache.
Yes, clearly a patient who presents pregnant or postpartum, elevated blood pressure, and they have a severe headache, you must analyze further what is going on. A CT is going to be helpful to make sure there's not a small hemorrhage, and you have to control their blood pressure. Carbon monoxide poisoning. Clearly, when there are multiple people from the same household with headaches and symptoms, nausea, vomiting, cyanosis, visual changes, altered mental status, coma, seizures, cardiac arrest, or ischemia, you need to get a venous CO level. Smokers may have one between 3 and 8% normally. Lethal is in the 40 to 60% range. We used to say, look, let's do hyperbaric oxygen therapy for a CO level above 24%. Now we generally do it only in patients who either have a frank MI, cardiac arrest, coma, or seizures. Otherwise, do high flow O2 for several hours and you can recheck the venous level. Now, what about head and neck infections? Remember, sinusitis, periorbital cellulitis, pharyngitis, retropharyngeal abscess, and lymphadenitis, all in and of themselves can cause headache, especially if someone's dehydrated and not tolerating PO. If they have a change in their headache or more pain with position change, you should think about sinusitis. Your head CT must exclude pansinusitis. If your radiologist does not say no sinusitis or sinus is clear, you yourself must look to make sure there is not pansinusitis. If you also must know whether it's periorbital, which is less severe than orbital cellulitis, and that must be done either through your CT or an orbital CT itself. Remember, common infections do cause headache, but when in doubt, give ceftriaxone prior to your head CT. That is the most important single move you can make. So let's now talk about COVID-19 considerations in the last few minutes. I pulled several articles. All of them have been published this year. We've gone from a situation where life was normal to a life that has clearly been changed based on the pandemic. So I just wanted to give you some insights as to mechanisms and diseases that have been observed and whether or not headaches are presenting differently based on COVID-19 or whether they are simply presenting more frequently because of this devastating virus. So this virus uses the ACE2 receptor in order to get access into your different parts of your body. These ACE2 receptors are in neurological tissues. They gain access to your brain through the nasal olfactory epithelium and through the capillary endothelial lining in your CNS. They literally invade your brain in those mechanisms. That's from this first article by Baig. Now let's consider another article by Wu. Other ways in which there's a CNS effect is due to hypoxic injury. Many patients are hypoxic due to the respiratory nature of this pathogen. And the immune response, the hyperimmune response or SIRS related to IL-6, for example, these can cause you to have infectious problems and or headache problems that may appear. They can cause actually encephalopathy, encephalitis, and acute cerebrovascular events through these two mechanisms, hypoxic and immune. Another article by Robinson talked about mechanisms, and one thing they pointed out is that you can get neuromyopathies, including Guillain-Barré, transverse myelitis, or flaccid myelitis. All are devastating diseases. You can get different viruses that cause these. We've known coronavirus, influenza, RSV, HMPV, and enterovirus all can cause these myopathies. Now, there's a direct neurotropism of these viruses. What does that mean? They have an affinity of going selectively to nerve tissue. So it's no surprise that patients with COVID-19 have headaches and or neuro problems. Berger published something talking about complications. The most common one we recall is anosmia and ageusia, the loss of smell and taste. But remember, we have myopathies, polyneuropathies, rhabdomyolysis, meningitis, encephalitis, autoimmune effects, post-viral, and the ones that we mentioned, such as Guillain-Barré. All of these complications devastating. What about a case report? Yin reported a case report of a Chinese patient, 64, temperature 38.5, cough, myalgias. He did not become unresponsive until 13 days after the diagnosis was made and had dissociated speech, clonus, positive Babinski and Chadic, and meningismus. The tests were negative and the patient amazingly recovered. But remember, it can take both a long time for these symptoms to occur and a long time for them to go away. Mao published something, an observational case series from Wuhan, China, 214 patients, 41% were considered severe and many had neurological complications. And they identified 36% of the patients who had neuro complications in three categories: CNS, such as altered mental status, dizziness, headache, CVA, ataxia, seizure, peripheral, taste, smell, vision, nerve pain, or skeletal muscle injury or rhabdo due to neuromuscular problems. Belvis published something regarding headache, doing a Medline search. He found thousands of patients that were described. Headaches were seen in 8 to 12% in 2 phases. And this is with all viral type illnesses that cause these problems. Acute headache in the viral infection phase, not a surprise, but a secondary time of headache when there is hypoxia and or cytokine storm noted. Belay published another examination of headache. It was reported in up to 1/3 of patients in the hospital with COVID-19. And the description was all over the place, much as like is true with many patients. They were new or sudden or gradual onset, moderate to severe, throbbing or pressure, and often had a poor analgesic response. They relapsed often. You got to tell patients to keep taking the pain medications. They were in the bilateral temporal, parietal, frontal, or periorbital areas. And bear in mind, there's also the possibility of trigeminal nerve involvement, especially due to the pro-inflammatory hypoxia or cytokine responses. Meningoencephalitis, 2 cases, a 64-year-old woman with no psych history. She was put in the psych ward, then had a tonic-clonic seizure. Her LP was consistent with meningoencephalitis. It was related to COVID-19. She was treated with acyclovir and amazingly improved. Another 67-year-old woman, COVID positive for 17 days. Then she had a headache, was confused, had bathroom syncope, stroke symptoms, was treated with acyclovir and antibiotics, and believe it or not, got better. So these 2 case reports by Bernard Valnet document how meningoencephalitis can precipitate complications as a result of COVID-19 infection. COVID-19 meningitis. Moriguchi published something recently. A 24-year-old, 9 days into symptoms, then was found unresponsive, emesis, lying on the floor, transient tonic-clonic seizures. COVID-19 was detected not peripherally from blood or swabs, but in the CSF. And in fact, there was MRI suggestion of meningitis based on positive findings in the lateral ventricle, temporal lobe, and hippocampus. Orbital cellulitis, I want to point this out. A 12-year-old Egyptian male had periorbital swelling. A 15-year-old male had 3 days of orbital swelling. And they found on the second patient pansinusitis, orbital cellulitis, and an epidural abscess. That's why it is absolutely essential that you exclude pansinusitis in any patient. And if you have pansinusitis, you must treat them aggressively. The first case, both cases required surgical intervention, and the second had a complicated course due to the pansinusitis that was noted and the complicated periorbital cellulitis. What about venous thrombosis? Hughes published something that found a patient, 59 years old, 4 days of frontotemporal headache, diabetic, hypertensive, and in fact, they had a thrombus. It was suggestive. The CTV was read as negative. The patient 4 days later had a progression in stroke symptoms, which is common. And then they reread it and found sinus defects in the sigmoid and transverse sinuses. They treated with low molecular weight heparin, and the NIH got better and they were discharged home remarkably. The last COVID-19 case we're going to look at is a 64-year-old male with a wake-up stroke, hemiparesis, was not given TPA. And it was turned out that 16 days earlier, the patient had fever, myalgias, and COVID-19. So delayed complication. The patient required intubation. The patient had evidence of high-grade carotid artery stenosis. A repeat CT was done. They found cerebral edema, mass effect, and both the middle cerebral and anterior cerebral artery territories. So this is a devastating complication that can be seen neurologically as a result of COVID-19 many days later. So in conclusion, with our ED headache patients and COVID-19, ED headache patient life threats can be identified A systematic evaluation is critical. The EMR can help you. We can exclude subarachnoid hemorrhage, the most important secondary life-threatening headache cause. Infection and thrombosis must be considered. And COVID-19 makes common headaches more likely to occur. And we need to consider COVID-19 with these headache life threats, but they do not necessarily present differently. They just present more frequently. And there's no need to alter our diagnostic regimen or treatment regimen just because of COVID-19. So our last question, and then we will go to your questions. All the following are true about headache and COVID-19 except. So the CNS complications can occur as a result of viral illness, direct attack, or secondary effects. COVID-19 can cause headache due to CNS infections and thromboembolic. C, COVID-19 causes illnesses to present differently when associated with COVID-19 or than without. And or D, COVID-19 complications can include CNS, peripheral nerve, and neuromuscular injury. So one of these statements is not true. Which of those is not true, please?
Okay, everyone. Again, bottom right corner, look for the polls button. People are voting already. I'll give you 15 seconds. Oh, this is going to be a close one.
Okay.
All right. As of right now, where 2/3 of the people are voting for C.
Yes, and C is correct. The way in which these illnesses present is similar to how they might present without concomitant COVID-19 infection. It's just that they are going to occur more frequently than you might see in your routine ED practice. So no need to change your diagnostic or treatment regimen. And with that, we can take some questions. Sam, it's over to you.
Ed, thank you so much for that exhaustive review. That was amazingly thorough and amazingly on time. I'm very impressed. We're going to move to questions now from all of you. You can submit a question by clicking on the Ask a Question button in the bottom right, or upvoting or clicking the little arrow next to a question if you think that's important and you want to see it answered. So we'll get to as many of these as we can here in the next 13 minutes.
Perfect.
The first one, which is the one that seems to have gotten the most upvotes, was the question about D-dimers and their sensitivity in ruling out cerebral venous thrombosis. So I know you touched on that a little bit already. What can you tell us about that in a little bit more of a focused piece?
Okay. Let's assume for a minute an older patient presents with the headache and they're having TIA type symptoms, and you say, gee, I wonder if it is CV thrombosis. If you believe ultimately they do not have that disease and they do not have significant risk factors, a history of thromboembolic disease, et cetera, if you believe they're low risk and you do a D-dimer and it's negative, it can help you to exclude the diagnosis. But remember, you pretty much excluded it based on your history and physical. If, however, you think they are at higher risk, you can't use a D-dimer to exclude it. You must either do an LP, do a CT, or do an MRV if the LP is showing high pressure or the CT shows any signs of increased intracranial pressure. Then you need to do an MRV. A D-dimer, obviously, in that situation is not going to help you, only in low-risk patients.
Okay, good. So stratifying them as low risk or high risk is going to be very important in that scenario.
Yes, even moderate risk patients for any reason can't be excluded with a D-dimer.
Okay. Another good question comes to us from Albert. So he asks, from an ED perspective, is it necessary to accurately diagnose the exact cause of a primary headache, tension, cluster, migraine, so long as you can confidently document why you don't think in your diagnosis any of the life-threatening causes are present?
Albert, that's a great question. I'll tell you this much. Often when patients present to the emergency department, I've discharged them with the diagnosis, acute cephalgia, head pain. And whether or not it's a cluster headache, migraine, or a tension headache is less important. As you have suggested, use your electronic medical record to document findings or the absence of findings, both historical and physical exam, that would suggest that they don't have a secondary headache that's either infectious or due to one of these life-threatening causes. Once you document the absence of a secondary cause, either infectious or life-threatening secondary cause, the exact etiology of a primary headache is less important.
Great. Another great question. So when we're looking at patients with COVID who have COVID-related headaches and thinking about management, are there specific things we should stay away from when it comes to managing their pain? And then are there, in the 2 case series you mentioned, they actually ended up treating patients with acyclovir, but is there really any evidence for using that as a treatment?
That's a great question. Patients who have severe headache and appear to have meningitis or encephalitis, acyclovir provides value, especially if they present with acute altered mental status and fever. Acyclovir, besides giving ceftriaxone or vancomycin, is indicated, and perhaps ampicillin if they're older. Now, the real question is, how do we treat them? I know 2 things. These headaches are refractory and they will come back repeatedly if you don't continue to treat them. I actually have just done a journal club search and have looked at the evidence that has been suggested by some that you should avoid nonsteroidals in the setting of an acute respiratory illness because it precipitates pulmonary complications and thromboembolic complications. And I can tell you the following. It is probably worthwhile to take Tylenol 1 gram 4 times a day and either take Aleve twice a day or ibuprofen perhaps 600 4 times a day. It is worthwhile to take that it does not itself cause pulmonary complications such as pulmonary abscess. It does not cause that. Nonsteroidals do not cause that. The reason that they seem to occur was because if patients took a lot of nonsteroidals, they didn't get their antibiotics as quickly because their symptoms were muted. In this case with headache, go ahead and treat the headache. I must tell you the one caveat, however, patients who are at risk for thromboembolic events such as MI or stroke, they probably ought to be careful with how much nonsteroidal they should use with any acute respiratory illness, because the literature is pretty good that there is increased thromboembolic risk with the use of nonsteroidals in the setting of acute respiratory infection with or without COVID.
All right. So you're managing their pain, but if they do have those MI history or the history of coronary disease, then you have to be
in the
line.
There is a caveat. They should use them, but use the smallest dose possible in order to achieve relief. And I would say, and doing the Tylenol 4 times a day is one way to minimize your need for NSAIDs.
Okay, good. Another question, again, related to COVID-19. In the cases that you mentioned with the orbital, periorbital cellulitis, is it thought that those were specifically complications of COVID or just coincidental infections?
That's a good question. That brings up a point that is overlooked clinically in discussing diseases such as this. Remember that every viral illness at some point can transition to a bacterial illness. And someone can have a mild viral upper respiratory infection and develop some component of sinus inflammation, but at some point it converts into a bacterial infection. And the point here is COVID, being a devastating disease, can bring on the onset of a bacterial infection more quickly. And so patients who present with COVID with headache, it's worthwhile to do a head CT, especially if the patient's known not to have headaches, because you must exclude pansinusitis. If there is pansinusitis, they need to be on high dose, multiple drug therapy antibiotics and admitted in order to prevent the occurrence of encephalitis or meningitis.
Good.
Especially because central venous thrombus can occur, especially with this type of disease.
Okay, good. Let's see. We got 5 more minutes, so a few more questions. Joaquin in Chile is asking us if there is any benefit to using ultrasound in evaluating some of these causes for headaches.
I'm not an ultrasound expert. I know in this particular monograph, they mentioned looking at the sheath diameter of the optic nerve, knowing that if that diameter is widened, that there's a suggestion of increased intracranial pressure. Aside from that, I can't comment specifically. I believe ultimately that the value of being able to perform a CT in a matter of minutes and knowing whether or not you can look, for example, at the brainstem and the stellate formation around it to see if there's a clear space. Those are simple things that can be done that would suggest the absence of increased intracranial pressure, such that I don't know that ultrasound can supersede the value of head CT because it's fast, it's safe, and it's available in most instances. Where it's not available, ultrasound may be of value, but I know that there are limited case series that demonstrate its effectiveness such that it would be used broadly in as opposed to using CT.
Great, thank you. Now, a question about CT and lumbar puncture. When we talk about evidence for getting a CT before doing a lumbar puncture, is that something you think is routinely recommended, or are there instances where you might just go, this is meningitis, we need to do the LP, get the antibiotics on board?
I'm aware, because I've worked with Fern and we've talked about unique neurological cases. I know of several cases where patients presented without altered mental status and they had no reason to suspect increased intracranial pressure, and they did a routine lumbar puncture, only took off 1 cc in each tube, and then patients have herniated. And you hear those cases, and I can only say the following. If it's possible to do a CT scan before you do an LP, especially because diagnoses such as CV thrombosis can cause increased ICP, or the idiopathic intracranial hypertension, or the Press syndrome, all of these can cause increased ICP. And it occurs to me that a thorough evaluation prior to lumbar puncture includes a CT unless there's an exceptional reason why that should not be done. That's my own opinion, and it's based on my experience and hearing about cases where ICP was unsuspected but turned out to be present.
Good. And let's do another question from Rebecca. So this is an elderly patient. She says, particularly with those who have advanced directives, DNRs, who are presenting with fever. Now she's asking if they have an infectious site and when you're looking for the source of the infection and the patient's confused, is it necessary, mandated, most recommended to go ahead and do an LP on those patients, or can you wait and go, I already have, I think it's going to be the urine, we'll wait. Do we have to go to LP right away?
That is a great question that has come up clinically several times in my career. We've asked that question, and here's the simple answer. If confusion in an elderly female is often related to urinary tract infection. So if they have a fever and confusion, must you do an LP? No. Can you wait to see whether or not they have an infection in their lungs and or in their urine? Yes. If you find an infection in either of those places, can you assume that that's the likely etiology? Clinically speaking, generally, yes. However, I would tell you again that if you know that you can treat pneumonia and urinary tract infections with ceftriaxone while you're wondering, and before you've got any results back, if there's fever, confusion in an elderly patient, give ceftriaxone while you're waiting to get the results of your CT, your urine, your chest x-ray. And then if you ever had to proceed to evaluating for meningitis, you can say it's already been treated in part, and then you only have to add vancomycin and or acyclovir if it turns out to be a viral etiology or some other etiology or cause.
Great. All right. In our last minute, we're going to hit 2 questions real quick. One is about hyperbarics. Is there an indication, or is it an indication to use a hyperbaric chamber for carbon monoxide poisoning in a pregnant patient?
Oh boy, good question. I've treated patients with CO poisoning who are pregnant. I am aware that in pregnancy there's higher risk with decreased oxygen delivery. I am not aware that pregnancy alone is an indication. The indications really boil down to severe cardiovascular and CNS complications such as MI and stroke or altered mental status or cardiac arrest that's resuscitated. I'm not aware that pregnancy alone is an indication unless it's well above the range of 24 and it approaches the life-threatening range.
Okay. All right. Well, everybody, it is 9 p.m. and we promised 1 hour. So I want you to be comforted by the fact that we're going to take these questions that we didn't answer and we will get Dr. Sloan's answers. Yeah. I want to say thanks to Dr. Sloan for an outstanding presentation today. And I want to say thanks to all of you for joining us today. In closing, I just want to remind you that tomorrow you should be receiving an email with a link to all of the additional content and the CME evaluation. Please be sure to complete that evaluation in order to get all of the CME credit. And if you don't get the email, reach out to us at www.ebmedicine.net/contact. Thank you again. And before we sign off, I want to say that we are going to be back in 1 week for the next webinar called 2 weeks, Timing and Triggers, an Approach to Patients with Acute Dizziness. Now that's going to be held on Wednesday, June 17th at 8 p.m. Be sure to go ahead and register early for your slot. You'll get an email with all of that information soon. And thank you so much for joining us, Dr. Sloan.
Hey, it's been great working with you, Sam. Thanks you to everybody from EB Medicine. And I have to tell you, the dizziness approach by Dr. Edlow, that monograph is excellent. It takes what can be a complicated issue and it stratifies it into some easily understandable clinical etiologies and treatment regimens. I look forward to it. If you have any questions, fern.org@gmail.com. God bless you all.
Thank you. Thanks, everybody. Have a good night.
Bye now. Bye, Sam.